deep hypothermic circulatory arrest. Then advantages are again the bloodless and motionless surgical field is there. We can avoid the clamping and manipulation of already diseased aorta. It is simple. We can, if the duration is okay, then we can simply perform the surgery, heart surgery. But disadvantages are that more the duration, more chances of injury are there. It is said that more than 40 minutes is always dangerous, but more than 60 minutes is always associated with the some type of neurological injury. And prolonged we need more time for cooling as well as for rewarming the patient. More bypass time will be there. Increased sort of complications from like pump-related complications like SIRS or pulmonary renal endothelial complications. Coagulation problems are again there. So then an editorial came in 2015 by Giovanni Battista Luciani. He said that it is like deep hypothermia in general or in particular has essentially vanished from aortic surgery armamentarium in favor of regional cerebral perfusion. Like nowadays, regional cerebral perfusion techniques are more popular. We should avoid using standalone DHCA. Now, coming to the second technique, this is the retrograde cerebral perfusion. It is used as an adjuvant to DHCA, and it provides the backward perfusion of the brain tissues. Like we perfuse the brain through the superior vena cava, it flush away all the toxic products of metabolism as well as embolic debris. It was first used in 1980s, while for aortic surgery, it was first used for brain protection in 1990. Now, basically we form a circuit. A bridge connects from the arterial and venous circuit of the bypass catheter is created. This is there is femoral line, femoral artery catheter. We maintain a line from this. This is a line for SVC perfusion, like retrograde cerebral perfusion through the SVC. And usually we maintain 10 degree Trendelenburg, and the flow rate is around 300 ml per minute. Usually people use 300 ml per minute, while at the end of the DHCA, they can increase the flow to about 500 or 700 ml to flush away the toxic metabolites. And this is the circuit we use. This is the femoral line, femoral arterial line for the bypass circuit, and this is the line which is used for the retrograde cerebral perfusion. Another simple techniques has been used by our surgeons as well. They have used the left internal jugular vein for retrograde cerebral perfusion. Then the advantages, as you know, short bypass, if the arch time is short, surgical time is short, this is a good technique, standalone technique. It is simple, the operating field is free of cannula. We can avoid direct cannulation of the supraortic vessels. While the problems are that DSCA there is rise in the intracranial pressure is there. There is chances of cerebral edema are there, and sometimes it is said that in animal studies there is inadequate perfusion to satisfy the cerebral metabolic demands. Now the clinical use, as I told you, if the short time is there, then we can use this technique, and particularly in older patients in which there is embolic load is there or there is atherosclerosis is there, we can use this technique. In those patients we can avoid the antegrade perfusion. Next is the selective antegrade cerebral perfusion. This is a technique nowadays most commonly used in complex heart surgeries. This is the history. It was first used in 1957, but the mortality is very high, was very high. Nowadays by Beckett and Katju, these are the two authors which have popularized this technique, and the moderate hypothermia was popularized in 1992 by Kazai. The method is like we do the selective cannulation of the supraortic vessels, or there is a continuous perfusion, cerebral perfusion with moderate hypothermic oxygenated blood, and it is the most physiological method of cerebral protection nowadays. And the cannulation nowadays, what we are doing is like we are cannulating the right axillary artery by the infraclavicular approach, and systemic cooling is done. And if the bilateral is to be used, then left carotid artery can be. But now that bilateral is rarely used, only the unilateral is okay for these patients. And this is the axillary artery which cannulated. This is the axillary cannula used for SACP, antegrade perfusion. This is how we put the antegrade cannula in the axillary artery, infraclavicular approach. And this is where we maintain this is the axillary cannulation. This is the NIRS we use intraoperatively. This is the rectal temperature we use. This is the nasal temperature. You can see nasal temperature is around 26, moderate hypothermia, and this is the rectal temperature of 28.5. Now again, the advantages are like it is a near physiological brain protection is there, brain perfusion is there. We can extend the circulatory arrest time to around 90 minutes, which is not achievable in retrograde cerebral perfusion or with standalone DHCA. We can improve the cerebral cooling as well as in moderate hypothermia. There is no need of deep hypothermic circulatory arrest. And various authors have used various authors. They have defined the incidence of around 4 to 5% of permanent neurological dysfunction or temporary neurological dysfunction, except in Ongino in 2008. The advantage is same. 90 minutes we can extend. We can use moderate hypothermia instead of deep hypothermia. These are the advantages of moderate hypothermia, like decreased excitatory amino acid, decreased calcium influx, protein kinase activity is decreased, and there is decreased formation of the reactive oxygen radicals. Disadvantages are technically more demanding. We have to cannulate the supraortic vessels, then additional equipment is required. If the embolism, if the atherosclerosis is in the supraortic vessels, then chances of embolism is there. And if it is like longer duration, more than 90 minutes, chances of cellular edema is still there with this technique. Now, there is a paper state of art paper which is published in Perfusion. They have also said that we can use SSEP for 25 minutes at moderate hypothermia, 28 degrees centigrade with flow rate of 10 mL per kg per minute. Another evidence whether we can use bilateral or unilateral, it is a meta-analysis of 1,500 patients by Angeloni, and they have also said that whenever both are equally effective, whether we can use unilateral or bilateral, basically the purpose is the circle of Willis. In 25% patients, the circle of Willis is not complete. So some say that we can use bilateral, we should use bilateral antegrade perfusion, but unilateral is equally effective. Another study by same authors, a meta-analysis around 6,000 patients, they have also said that whenever the prolonged cardiac arrest is there, we should use bilateral antegrade perfusion instead of the unilateral antegrade perfusion. Another paper published recently by Leipzig, they have said that it's the best technique for cerebral protection in arch surgery, antegrade selective cerebral perfusion with adequate hypothermia. Then there is a European survey was conducted in 400 centers, and they have used, they have surveyed the centers, and they have concluded that we can maintain the perfusion pressure of 40 to 60 millimeter of mercury with bilateral monitoring of perfusion pressure. Flow rate is around 6 to 10 millimeters of mercury, mLs per kg per minute. Temperature of around 20 to 30 degrees centigrade. And SSEP maybe usually it is unilateral, but whenever the duration of arrest is more than 40 minutes, we can use bilateral antegrade perfusion. And cellular monitoring should always be used in the form of NIRS.